it will cause ACTH to be low. So ACTH is going to be integral in your ability to differentiate adrenal origin Cushing's from up here, okay? And this is what we call primary again, but we call it Cushing syndrome. Secondary up here. So because it's not primary, speaks about the end organ, the last organ that makes the hormone. So as I said here, it is high, it's not adrenal disease. We spoke about Cushing last week, and I did ask you to go and look in your books to see these nice diagrams. Different textbooks have different pictures, but this is showing you, I don't know if you have access to the slides after, a plethora of presentations that may be seen in Cushing syndrome. But of all of what you're seeing on the right side, the ones I want you to pay close attention to are the ones on the left, okay? Because the obesity pandemic is significant. A lot of people with plain obesity will have a lot of the signs that we're seeing on the map, right? But the ones that will say, yes, this is likely to be Cushing syndrome are the ones here. So the people are obese, yes, but they have plethora to the face or hyperemia, redness. They lose very easily. Sometimes they can't even remember where they got the trauma from. They just have black and blue spots all over. You don't have Cushing. I don't know what you're looking for. So proximal weakness as well. So they're trying to get up from a chair and they have to use their arms to help to lift them up, especially if the chair is lower, right? It's telling you that there's proximal weakness in the lower legs, or they're trying to comb their hair or hang up clothes or do something like this, and they have to take it down quite often because they have proximal weakness.
Is the purplish striae on the abdomen?
So the purple striae are usually, I didn't even get there yet. You're jumping in. But yes, abdominal purple striae, they're wide, more than a centimeter wide, they're hyperpigmented. So looking at dark people like me, it's not going to look purple. It's just going to look hyperpigmented. In somebody who is of lighter hue, a lower hue Curtis score, whatever they call it in dermatology these days, you might see that it looks purple. But whatever it is, it's hyperpigmented, it's not pale, and they're white, okay? Also, in children who are stunted, children who are not growing, I know we're not in pediatrics now, we're speaking about adult medicine, but you'll be exposed to pediatrics. Patients are just not attaining their height, but they are growing sideways, so the obese, stunted child is the one as well that you want to have a high index of suspicion about. And the final thing, somebody with osteoporosis. Osteoporosis is a disease of elderly people, people who are in their 50s, 60s, 70s, 80s. Somebody comes to you, they did a CT scan, spine or something else, and you're seeing they have vertebral fractures. That's telling you they likely have osteoporosis and you need to consider Cushing's. So yes, we have a long list of things that can happen in terms of clinical features here, but the ones that are more discriminatory of Cushing's are the ones to the left. Alright, so how do we diagnose Cushing's? Now we did this last week as an introductory piece. We want to screen the patient. So the patient comes in and they're complaining of some of the signs that we saw symptom-wise. When you examine, you're seeing some of those clinical features, so you want to test the patients. And we always start out by screening, and there are several screening tests that are available. They're listed here. You can ask the patients to do 24-hour urine-free cortisol. So we never screen Cushing's with spot cortisol. That's just not how it's done. The spot cortisol is used for hypoadrenalism, which we speak about before. We're talking about excess now. We want to do 24-hour, full 24-hour collection. So the patient has to be told how to do that properly. Nothing can go in the toilet for that 24-hour period. But because the sensitivity of the test is low, we do 3 of them. So 3 different days, 24-hour urine-free cortisol. And we're looking for elevation in the urinary-free cortisol of about 3 times normal, 2 to 3 times normal. So if it should be 50, and it's 75, we don't consider that elevated because there are some things that can cause a slightly elevated UFC or urinary free cortisol. We want to see that more than 150 going up to 200. And we do 3 of them because we know the sensitivity is low, so doing multiple tests increases the sensitivity. Okay? It's hard to do, it's hard to your, it's inconvenient to say the least. You have to collect your urine in a container at home, you have to stay home pretty much because you're not going to be walking around with pee all day at work or at school, so you have to have a day off each time to do that. And you might sometimes forget and urinate in the toilet inadvertently, so the urinary free collections or the total collected urine is lower than what you actually pass for the 24 hours. So you may have an abnormally low number, and that is not going to be the legal. So the patient has to be able to really follow instructions to the T. Otherwise, we can do what is called the 1 milligram overnight dexamethasone suppression test, and we spoke about that last week. It's a feedback test. So you're giving the patient some steroids, 1 milligram of dexamethasone at 11 o'clock, and then in the morning at 8, we want to check cortisol levels. If the person who is normal, remember you've given extra cortisol, you expect it to go a little bit more. If it's not less than 50, then that is not suppressed, and you have to move on to a higher dose. Okay? You have a question?
It's a quick question. For the 24-hour urinary free cortisol test, is that done in patients who are admitted to the hospital?
No, we send them home, we write the lab sheet, send them to the lab gives them 3 big bottles, and the lab also explains how to do it. But we can't do it in hospital, but it's usually an ambulatory test.
I just thought it would be in hospital because you're more likely to be able to monitor what's happening with the patient, so the test will be more
That's why you
accurate.
choose which patients you do it in. If you think the patient is not going to follow the instructions, you do another screening test.
Okay, thank you.
So if it's greater than 50, you know that there's a problem with, and then despite negative
It's
feedback.
not as straightforward as that. So if it's greater than 50, it means the patient has not suppressed. Okay? So we're suspecting it's not diagnostic. It's a screening test. So if it comes back positive, we can't say yes, everybody with a positive test will have a problem with their adrenal glands. We're going to now move on to a higher dose test, which is what we call the low dose. So the 1 milligram is, as its name suggests, a 1 milligram overnight dexamethasone suppression test. If that is positive, then you move on to your low dose dexamethasone suppression test, where you give the patient more steroids to see if it will now suppress. Okay? Because you have some people have false positive. So when you give them a higher load of dexamethasone, if they now suppress, you can say, okay, they don't have Cushing's. But so what I said is that if the patient's 50 milligram or 1 milligram is positive, you move on to the lower dose, which is 0.5 or 6 hours. So you get 2 milligrams for the first 24, 2 milligrams for the next 24. 0.5 every 6 hours works out to be 2 per day, and you do that back to back for 2 days. You're starting with a baseline cortisol, which you do before the first dose, and if this cortisol number is say 120, and you completed the test, you test the cortisol again, you expect it to be less than 60. You expect a less than 50% drop in persons who have the disease, and more than 50% drop in persons who don't have it. So if you're normal, and you go to the lab, you do a morning cortisol is 200, I give you 0.5 every 6 hours for 2 days, and you go back on the last day, and you have a check again, and it's 50, then I know you dropped back more than 50%, which would be 100, and so it's unlikely that you have Cushing's, so your body has responded appropriately to that higher dose. But if you're the same person, you do have Cushing's, go to the lab, 200 on the first morning, you get for 2 days, you come back and it's 150, it's only dropped like 25%, right? And so we know that you have failed that test, and it's likely that you have Cushing's. So we're looking to see that your body responds in an appropriate way. If your body responds appropriately, unlikely that you have it. If your body does not respond appropriately, it's likely you have it. And then we're going to move on to imaging and so forth. But the bottom line is really understanding the feedback loops. If you understand what should happen when you give extra this, then you will, the rest is straightforward. You do have a question.
The range that you have, less than 50 to
Alright, so don't be too caught up with the numbers, guys. So that's nanomoles per liter is what you would look for in a normal person with an overnight decimal suppression test. But don't try to remember numbers. What I want you to get is a concept, okay? It should fall to below normal, and with a low dose, we want a less than 50% drop to say yes, you think you have it. If it's so, whatever your number is started up, you started off at 300 and you're normal, we want it to come down to less than 150, okay? So we're not too fixated on the actual numbers, but it's really the concept that we want. Nobody's going to really hold you to any numbers at your level. So don't be worried about that. But there are things that can cause the 24-hour test to be false right? And we alluded to it. You didn't collect all of your urine, so it was normal when it should be high. Or if you have a low EGFR, your filtration, if you're not passing out enough urine over that 24-hour period, then it might also see false. So you have to again pick the patient who you're choosing to do so. If somebody who has CKD and a low EGFR, this is not going to be the test for you. The same thing applies to the ONDSD. You can have false positives and false negatives. So think about it. I'm giving you some dexamethasone, and you're on a medication which induces excretion or elimination of dexamethasone. So I gave you 1 milligram, and you're on, say you're on phenytoin for seizures, and as soon as you swallow that 1 milligram, you're metabolizing it very quickly. And so it's almost like I gave you 0.25 milligrams. So you can't believe those results. You have to look at the medications the patient is on and try to eliminate, try to tease out what might affect the dexamethasone metabolism and decide if this test would be ideal for you. So if that's the case and the patient is on any of these, you might want to use another screening test, okay? The same applies to somebody who is on oral contraceptive pills. That increases the total amount of protein in the blood, cortisol binding globulin, and this binds a lot of cortisol, and so your cortisol levels generally will be higher. And so even if you don't have Cushing's and you're on oral contraceptive pills, it might suggest you have it. So that's why I'm saying you can't really just take the numbers just off the bat. You have to screen the patient, do a full history, look at all the medications, and decide on what test you think would be best for them. Okay? Other tests, other screening tests, so we spoke about the urine, we spoke about the dexamethasone suppression test. Late night saliva cortisol. So remember cortisol is produced, or not remember because you have another physiology yet, but it's up and down. It's not a straight amount of cortisol that you have in your system for the whole 24 hours. And at night time, you reach a nadir. So the lowest amount of cortisol that you should have in your system is at night. And then when you're waking up in the morning, the cortisol levels will increase, and that's getting you ready for the start of the day. So if you wanted to check the patient to see if they're making too much cortisol, the perfect time to do it would be at night. If it's elevated at midnight, that is totally abnormal. That's the time you should be asleep, your cortisol level should be the lowest. And so if you were to offer them late night saliva cortisol testing, where they chew on a little piece of cotton, send it to the lab, they test the cortisol in saliva, which is actually one of the most sensitive tests to do, most convenient. Patients don't have to go to the lab, they just get a thing to chew and then bring it back at a convenient time for them. Then that will tell you it's above a certain amount. That is absolutely not normal. But you can't use these tests in shift workers or when students will stay up a lot at night and sleep during the day when they should be in their classes. Alright, so we already spoke about those definitely. I'm not surprised on you guys. I don't know how
the week is 12 a.m. So I don't know.
Alright, so how you manage the patients, no? Again, if you have something that's making too much of something in your body and it's causing all of these complications that we mentioned potentially, you want to take it out, okay? We're not going to say go to medical therapy alone. We want to say go to general surgeon and have them laparoscopically remove it. Of course, if it's larger than a certain size, if it's more than 6 centimeters, we want an open cut because this could potentially be malignant, and we want to make sure we remove all of that adrenal bed that we can to make sure we don't leave any tumor behind. So the larger lesions, we typically would say open adrenalectomy because of the reasons we discussed before. The smaller ones should be fine to go ahead and do and laparoscopic type adrenalectomy. But of course, not everybody can undergo surgery. So we spoke about primary aldosteronism already, and we said if they can't do surgery or if they don't want to do it, there are medical options available. The same is the case of Cushing syndrome. Patient cannot tolerate surgery or they refuse it, even though the definitive management is surgical. We're going to say medications are out there which can block the production of cortisol. And one of those medications is tyrosine. It works on these enzymes that we've outlined here, 11 beta hydroxylase, by blocking them. And so you don't have a lot of aldosterone or cortisol being produced, but you have to monitor the patient's adrenal insufficiency, because if you're blocking off all of these vital hormones from being produced, then you're going to become very deficient, and that can be a problem as well. And these patients may actually start to show features of hyperandrogenism, because they have a lot of these precursors being shunted to the side that is unblocked, and these women start to show features of excess testosterone or sex hormones. Alright, so we're going to speed it up a little bit because we have a little time, but I'm glad you're engaging. The final one from the adrenal cortex. So we spoke about aldosterone, which is the salt. Spoke about glucocorticoids, the sweet, and now the sex hormone. These are androgen secreting tumors, okay? So they make sex hormones, and these are the ones, the androstenedione and the DHEA. So we have just let the lecturer at the back know that
Yes.
5 minutes were taken out of my time, and so I'll be 5 minutes behind. Thank you. So these are the ones. Androstenedione and DHEA, okay? Yes, we spoke about ACTH, which is made in anterior pituitary. It also promotes androgen production. But I highlighted the second point to say that our worry is not the top, because our problem is not ACTH excess here. That would have been the case if it were coming from up here. Our problem is really originating in the adrenal glands, and we're making a lot of these hormones. Also remember that your ovaries make excess testosterone, and it also makes excess androstenedione. So when you're checking the patient to see whether this hirsutism and clitoromegaly and so on, when these are present, so the clitoris for the woman would enlarge if she's making too much sex hormones. She will start to have balding in a pattern that looks like older men. So as men get older, and then there's the side of the hair and top and so on. That can happen to these women. The bodies become weak and they start to look very bulky as though they're on steroids. It's very difficult to pick up with the men because it's normal for men, right? So with the women now, when you see these things happening, you want to check their sex hormones. And the ones that I spoke about are here, androstenedione and DHEA plus testosterone. But these are the ones that are going to discriminate, tell you that yes, something is going on in the adrenals, because testosterone can be made elsewhere. So yes, the testosterone is going to be high, but are these adrenal sex hormones also elevated? And those are the ones that you should ensure that you check to make sure that you're able to discriminate where the pathology lies. Alright, so how are you going to say the woman has hirsutism? It's going to be, it's dependent on ethnicity. So there are some ethnicities in which women have more here, right? So a higher number would be acceptable. But typically we use these numbers, and this is what we call the Ferriman-Galloway scoring system. You just add up all of these years depending on what the woman looks like. And if it's 8 to 15, we call it mild hirsutism, and it's more than 15, it's moderate to severe. Okay? And biochemistry, as I mentioned, we do testosterone, which would be elevated, but if it's less than 5, it would tell us that it's very unlikely to be a malignant cause. Okay? DHEA, DHEAS, remember we said we want to look for the sex hormones that are coming from the adrenal gland. Not just the testosterone, but you're also looking at DHEA and androstenedione, because we know those originate from the adrenals. Yes, if it's elevated, we want want to do your CT scan of your adrenals. If you think it's ovarian in origin, you want to image the ovaries, and then the management is going to be surgery. Okay? The last thing that we're looking at now, and I have 7 minutes. So we spoke about the adrenal cortex already in the entirety. We spoke about the zona glomerulosa, which makes mineralocorticoid, zona fasciculata, which makes glucocorticoid, zona reticularis, which makes sex hormones, and now we're speaking about the medulla, okay? That's the donor, that's the jelly part of the donor, and it makes the excess catecholamine. These are actually rare tumors. They come from chromatin cells, and yes, we're speaking about adrenals here, in which case we call them pheochromocytomas. But these chromatin cells also lie external to the adrenals, okay? In the autonomic and parasympathetic chain can be present from the base of your skull all the way down to your bladder. And if they're external to the adrenal, we don't call them pheochromocytomas, we call them paragangliomas. So you will see PPGLs, pheochromocytoma, paragangliomas. That's a mnemonic for them. Like I said, catecholamine excess. It may be genetic or sporadic, so that individual might be the only person you dug and dug and dug in the family history. They can, come up with anybody who presents with anything similar to them. So they're the first person in their family. This is the index person. But sometimes it might be genetic. They may have family members with similar conditions, and sometimes it might be syndromic. So syndrome, different diseases coming into one entity. So some of the syndromes are multiple endocrine neoplasia, 2A and 2B, or what we now call 2 and 3, as well as one people live now, and we won't go into all of the different components of the syndrome, as well as neurofibromatosis 1. Okay? Symptoms. Not a mnemonic here, PhD. I don't know how many of you aspire to have a PhD, but the classic triad, the symptoms for pheochromocytoma paragangliomas are palpitations, headaches, and diaphoresis. Not everybody is going to have hypertension. Most people with pheochromocytoma will have hypertension, okay? But the symptoms, palpitations, headache, diaphoresis, symptoms are very often episodic. So I'm sitting down here, I'm feeling okay. 5 minutes later, all of these symptoms rush me. They last for about a few minutes, and I have a break again, and multiple times for the day, multiple times for the week. So it's not usually ongoing symptoms, or different things may actually bring the symptoms on. So excessive activity, somebody kicking my abdomen, and it causes the lesion to start to liberate a lot of these catecholamines. Trauma, excess activity, etc. But there's some other symptoms to the right. We won't spend time going into each of them. Before you go to screening, again, we spoke about screening for primary hypoaldosteronism before, and we have a long list of people in whom you need to make a test for that screening. For pheochromocytoma, this is another list. So adrenal incidentaloma, we spoke about that already, starting from the bottom here. Somebody comes in heart failure, and we can't figure out why. They have no risk factors. Sudden onset heart failure, unexplainable. Patient is going for the same appendicitis treatment, and in surgery they have a hypertensive crisis. As soon as you expose them to general anesthesia, the blood pressure goes up to 240 over 160, and the anesthetists have a rough time in there, managing the blood pressure. Resistant hypertension, and we told you what that is already. Hypertension in the young again, especially if it's less than 30 years old. Patients with these symptoms which are paroxysmal, not all the time, but up and down, on and off. And of course, if they have a family history of somebody with a genetic mutation, that we know leads to PPGLs. Right, so you can actually try to figure out if these things are paragangliomas or actual pheochromocytoma. Remember we said pheo is in the which organ? The adrenal gland, paraganglioma is outside of it. They have this enzyme here. I don't know how many of you will attempt to pronounce it, but it converts norepinephrine to epinephrine. Okay, so enzyme, and so they're not going to be converting norepinephrine to epinephrine. So if you see there's a predominance of norepinephrine, then perhaps it's not an adrenal origin for your problem. So complications, again, all of those complications related to hypertension. This should be a cardiomyopathy, LVF, etc. You can all read that afterwards. And how we investigate, we check either urine or blood for the catecholamines, and if those are positive, then you're going to image with a CT scan, you're activating, okay? And of course, we want to treat the patients by using alpha and beta blockades. Hypoadrenalism, we know that this is due to deficiency in the production of hormones, and the causes may vary. You're seeing them all here, and you're deficient in mineralocorticoids and glucocorticoids, and this is how the patients will present. Remember, I said hypokalemia for excess aldosterone, it will be hyperkalemia for deficient aldosterone. It's the opposite that you get from the testing. And again, we spoke about the dynamic testing. We want to stimulate if you think it's under production, so you think it's deficient in adrenal hormones, you want to use ACTH, try and stimulate to see if you're able to produce. And the management is going to be replacement. So you don't have enough glucocorticoids, you don't have enough mineralocorticoids, you want to give the patient the replacement, right? Like tablets, all right? So summary slide, and I know we rushed, I've ended exactly at an hour, having started 5 minutes late. This is a summary. Cortex and medulla, remember the layers, remember the mnemonic. Different hormones are made by layer. The medulla is the one that's in charge of making catecholamines, and diseases will be related to whether the problem is causing excess or deficiency, and the symptoms are going to be there. We rush the second part of it, but you can always read, and it's pretty straightforward. If there are any issues, you can always email me. And we will start and dynamic testing for adrenal disease. Once we've made a diagnosis, we want to image with a CT scan. CT is the best. We did say MRI for pituitary, CT for adrenal, and then surgery is the mainstay of treatment. If it's excess, if it's deficient, then we want to give replacement hormones. Okay? Thank you guys. We have our next lecture, which I won't be in this time, but reach out to me